Welcome to this clinical explainer on Pityriasis Rosea. It's a really common skin condition and definitely a high-yield topic for any specialty exam. All the content you're about to see comes from Dr. Mohammed Al-Naji Mohammed. Okay, here's our game plan. We're going to start with the basics, what this condition actually is. Then we'll walk through how it shows up, from that first herald patch to the main rash. After that, we'll tackle its biggest lookalike, gutted psoriasis, which is a classic point of confusion. And finally, we'll wrap up with how to manage it. All right, let's dive right in. First things first, what exactly are we talking about when we say Pityriasis Rosea? So at its core, Pityriasis Rosea is an acute, self-limiting rash. Acute just means it comes on pretty quickly, and the really important part is self-limiting, meaning it goes away all by itself, no treatment needed. Now, we don't know the exact cause for sure, but there's a pretty strong theory linking it to the reactivation of human herpes virus 7. Here's a key clinical pearl for you. Even though we think a virus might be involved, most patients don't remember being sick recently. A few might mention a cold or something, but it's not the norm. So if your patient doesn't report a recent illness, that definitely doesn't rule out Pityriasis rosea. Okay, let's get into how this actually looks on a patient. It all starts with its most famous sign, the herald patch. This thing is what we call pathognomonic, which is just a fancy way of saying if you see it, you're almost certainly dealing with this specific disease. And here it is. This is that classic herald patch. It's a single, pinkish-red, oval-shaped spot. You can often see a little ring of fine scale right around the edge. It usually pops up somewhere on the trunk, and it shows up about a week or two before the rest of the rash kicks off. So, once that single herald patch has made its appearance, the next stage begins. The condition evolves, and you get a much more widespread secondary rash. Now, this secondary rash is made up of a bunch of new spots. They look a whole lot like the herald patch. They're the same pinkish, oval, scaly type of lesion, but they're just smaller. Now, check out these images. The distribution of this secondary rash is a huge clue. It has a real preference for the trunk, right? In a classic case, you won't see much, if anything, on the face, palms, or soles of the feet. But here's the really cool part and a major diagnostic giveaway. The long axis of these little oval spots actually lines up with the natural skin tension lines, which we call Langer's lines. On the back, this creates this incredibly distinctive pattern that we call a fir tree or Christmas tree distribution. And this picture shows it perfectly. Just look at how those oval spots are oriented. They're pointing down and out from the spine. It really does look like the branches of a Christmas tree. When you see this pattern, your diagnostic confidence for Pityriasis rosea should go way up. Okay, so with that classic picture in mind, we have to talk about its main imposter. Differentiating Pityriasis rosea from this other condition is a super common challenge, both in the clinic and on your board exams. This is the question you have to ask yourself. At first glance, they can look pretty similar, but if you know what to look for in the patient's history and on the physical exam, you can definitely tell them apart. So let's break down the key differences using this table. First, the prodrome. Gutted psoriasis is famous for showing up a couple of weeks after a strep throat. That's a huge clue that's usually missing in Pityriasis rosea. Next, the look of the lesions. Gutted psoriasis has these classic small, teardrop-shaped spots, whereas Pityriasis rosea has that big herald patch followed by the smaller oval ones. The distribution is also different. The fir tree pattern is unique to Pityriasis rosea. And finally, the timeline. Pityriasis rosea is usually gone in about 6 weeks, while gutted psoriasis can stick around for months and might even need treatment. All right, so you've put the pieces together, you've ruled out the mimics, and you're confident in your diagnosis of Pityriasis rosea. So, what do you do for the patient? This is it. This is the most important part of management. Because it goes away on its own, your main job is to educate the patient and reassure them that this is a benign rash that will resolve. Now, if it's really itchy, you can suggest some moisturizers or maybe a mild steroid cream for relief, but you're not actually treating the condition itself. And this is the number you want to give them. When they ask, "Doc, how long will I have this?" you can tell them that it typically clears up completely, without any scarring, in about 6 to 12 weeks. Setting that expectation is key. So let's just quickly summarize the key takeaways. Your diagnostic process should be 1. Hunt for that initial herald patch. 2. Identify that classic fir tree pattern. 3. Actively rule out gutted psoriasis by asking about a recent sore throat and looking for those teardrop lesions. And 4. Once you're sure, your main job is just to reassure the patient that it's all going to be okay.
And we'll end with one final critical thought. We've established that this is a benign condition, but you should always be thinking, are there any red flags? Are there times when this rash might not be so benign? Absolutely. If you see it on the palms or soles, if there are severe sores in the mouth, or if the rash just isn't going away after 12 weeks, you need to start thinking about other possibilities, like secondary syphilis or a drug reaction, and that warrants a deeper workup.